Okay, so a warm welcome to everyone present. So we have already been introduced to the world of pediatrics, and now we are moving further into the depths of our basic module in pediatrics and neonatology. So to start with today, we are delighted to have with us Dr. Priyanka T. Nair. She is working as clinical pharmacist in the Department of Pediatric Neurology at Amrita Institute of Medical Sciences. Priyanka has an extensive experience in pediatric neurological care, and she has also presented research papers in national platforms. She's also a very active member of our forum. So today she'll be guiding with us through a very important topic, that is patterns and determinants of growth. So this is a very important as well as a basic topic for our pediatrics. So over to you, Dr. Priyanka.
Thank you so much, Jubiji. So this is patterns and determinants of growth. I do not have any disclosures to reveal. So let's start with a question. Have you really observed a growing child? If you answered yes, let's see if your answer remains the same by the end of this presentation. So the learning objectives of this presentation are going to be what growth is, how it takes place, and why it happens. Then we'll learn about factors driving growth, followed by different phases of growth, and then finally the diagnosis and management of growth disorders. So growth, in simple terms, is the net increase in the size or mass of tissues achieved through multiplication of cells and an increase in the intracellular substance. Growth is a very visible phenomenon, and it helps us to differentiate between a 1 month old to a 10-month old or to a 2 year old. Now, coming back to our initial question, have you really observed a growing child? If you have, you would have noticed that the head size of an infant is only 1/4 of its total body length, while when the same child transforms into an adult, it becomes 1/8 of the total height. Let's see how this transformation takes place. First of all, let's learn about the laws of growth. So, growth of children is a continuous and orderly process, but the speed of growth varies. In the prenatal phase, that is before birth, the fetus grows fast in the first half of gestation, then it slows down until birth. After birth, that is the postnatal phase. There is a high velocity of growth during the first few months. Then it is followed by a slower but steady phase during mid childhood. Then comes the second phase of accelerated growth. That is the time of puberty, post which it decelerates and then stops altogether. The second rule says that the growth of every individual is unique growth pattern. That is the cephalocaudal pattern and the distal to proximal pattern. Now, cephalocaudal means that, especially at the time in the prenatal phase, the head forms first, growth of the head takes place, and then the trunk followed by the lower body. This is the cephalocaudal growth pattern, or from the top to bottom. And distal to proximal pattern is seen during the adolescent growth spurt. That is the growth of the fingers, then followed by the limbs, then followed by the trunk. That is the distal to proximal growth pattern. Also, we see that different tissues grow at different rates. For example, the growth of the brain is rapid during the first 2 to 3 years of life. That is till the first 3 years of life. Then it is followed by the gradual phase and then it reaches a steady period. While in the case of gonads, they remain dormant till adolescence, after which they grow rapidly. In the case of lymphoid tissues, the growth actually is the most during the mid childhood. And this is evident because we've seen that in case of children of 4 to 8 years of age, they have very palpable lymph nodes and they can be evidently seen. In case of body tissue, body fat and muscle mass, basically we have different two types of body tissues. That is the fat and fat-free components. The lean body mass includes muscle tissue, internal organs, and skeleton. and they contain only a small amount of fat. The growth in the lean body mass is primarily due to increase in muscle mass, and this closely relates with our stature. The skeleton is mature once the epiphysis or the growth plates at the end of our long bones fuse fuse to the diaphysis or the shaft. Okay, so because of this, taller children have greater lean body mass than shorter children of the same age. Now, after the pubertal spurt, boys have greater lean body mass as compared to girls, and body fat is this. Now, coming to the fat components, that is, the body fat is the storage of energy. It is primarily deposited in the subcutaneous adipose tissue, and we've seen that in girls there is more subcutaneous adipose tissue than boys. Okay. So, in summary, growth is a complex multifactorial process influenced by an interplay of genetic, hormonal, nutritional, environmental, and infectious psychosocial factors throughout fetal life and childhood. Now, let's see what are these factors. Okay, so the first category of factors are fetal factors. In factors, we have first of all genetic potential depending upon the parental traits. That is 40% of variation in birth weight is because of genetics. Whatever we are inheriting from our parents, it is seen in the birth weight, like in birth weight, head size, and height. And secondly, we have seen that male fetuses are generally taller and heavier at birth. Then we have our fetal hormones coming into play. The fetus secretes thyroxine and insulin, which helps in tissue growth and differentiation, especially in the late gestation period. Also, glucocorticoids contribute to organ maturation. Apart from this, the fetus also secretes these growth factors called IGF-1, IGF-2, EGF, nerve growth factor. All of these help in cell division and tissue growth through autocrine and paracrine actions. Now, all of these factors act, but some of them promote growth and others inhibit it and maintain a balance this way. Second category of factors are placental factors. Placental weight is very closely related to the fetal weight. Why? Because placenta is important for nutrient and oxygen transfer. In case of a well-functioning placenta, it undergoes structural and functional adaptation, such as increased villus surface, decreased diffusion distance, capillary dilation, and reduced vascular resistance to meet the fetal demands. And in case of placental insufficiency, that is a not properly functioning placenta, we see that it impairs fetal growth and leads to conditions like IUGR or intrauterine growth restriction. Then we have the maternal factors, that is mother's health, nutrition, and body composition at the time of conception and during the throughout pregnancy. We see that there are factors that adversely affect growth. That is teenage or advanced maternal age, recent pregnancies, high parity, anemia, tobacco use or drug use, pregnancy-induced hypertension that is termed as preeclampsia, multiple pregnancy and chronic maternal illnesses. All these factors adversely affect the growing fetus's growth. Then, among the postnatal genetic factors, postnatal is after birth. There is growth retardation seen because of chromosomal abnormalities like Turner syndrome and Down syndrome, while in the case of other genetic conditions like Klinefelter syndrome and Soto syndrome, we see a tall stature. Then, intrauterine growth restriction and low birth weight. These two are very closely related because this affects growth in a very important way. Intrauterine growth restriction would lead to low birth weight because of the non-expansion of the uterus as needed by the fetus. Then there are hormonal influences. that is growth hormone and thyroxine in their normal amounts would lead to proper somatic and skeletal growth, while their deficiency would lead to dwarfism. On the other case, androgen and estrogens would lead to growth spurts during puberty and contribute to the final adult height. On the other case, we have hormonal imbalances that disrupt normal growth patterns. Then, nutritional factors play a very important role, especially in the postnatal period. That is, we've seen that deficiency in calcium, iron, zinc, vitamins A and D, protein, energy, malnutrition, and anemia would lead to low growth rate, while an accelerated growth rate is seen in overnutrition and obesity, but that may lead to other health conditions, which we'll see later in this presentation. Then infections, that is recurrent infections may lead to impaired growth. This is seen in case of infants when they have recurrent diarrhea or respiratory tract infections. And finally, we have social and environmental factors. Socioeconomic status in which the child growth influences nutrition, hygiene, and infection rates. Poverty, hunger, undernutrition, and high infection rates would lead to a lower growth rate. Natural resource availability and economic growth may improve the community nutrition and child growth. Climate also affects growth because it affects growth velocity by influencing disease prevalence and food availability. Apart from this, there is emotional factors like anxiety, insecurity, and lack of familial support, which leads to reduced growth hormone regulation and impairs growth as such. So all these factors come into play and affect growth. Understanding of these factors is very important for promoting optimal growth and identifying growth disorders. So we've seen that all these factors lead to growth up to adolescence and suddenly it stops. But did you know that there are two organs that appear to grow throughout our life? Yes, these are this is the nose and our ears. They appear to grow because of the presence of cartilage in them. So basically, the cartilage is an elastic substance. Because of the effect of gravity, the elasticity increases, and because of that, it appears to grow, but actually they are just drooping. Have you observed this? Okay. Next up, we have different phases of growth. So in the prenatal phase, from the first or from the 0th day, that is the day of conception, to the 14th day of gestation, we have the ovum, which is the fertilized ovum, and it undergoes initial cell divisions. Then, from the 14th day to the 9th week of gestation, the embryo undergoes rapid multiplication and differentiation, forming tissues and organs. Then, the fetus from 9 weeks to birth. Birth usually happens around the 37th to 40th week of gestation. Here, it continues growth with increase in cell number and size, and there is organ maturation that takes place all through the gestational period. Then there is a perinatal period, which is a combination of prenatal and postnatal period. That is from the 22nd week of gestation to the 7 days after birth. This is the period that is very crucial for survival and initial adaptation. Now, in the postnatal period, till 30 days, this child is called a newborn. There is rapid growth and adaptation to extrauterine life. Then, from the 31st day to 1 year, the child is called an infant. There is high growth velocity, doubling of birth weight takes place by 5 months, and tripling takes place by 1 year. Then, from 1 year to 3 years, the child is called a toddler. There is a steady growth with gradual slowing of velocity compared to infancy. Then comes the preschool child, which is the age of 3 to 6 years. Then where we have continuous steady growth, acquisition of motor and cognitive skills. Then school age child is from 6 to 12 years. There is moderate growth velocity and the body starts to prepare for pubertal changes. Then adolescence from that is the early adolescence from 10 to 13 years in girls and 12 to 14 years in boys. Here we see that start of pubertal growth spurt takes place. There is rapid increase in height and weight. Then there is middle adolescence, which is 14 to 16 years for girls and 14 to 17 years for boys. There is peak height velocity. Sexual maturation also starts taking place. Then there is late adolescence from that is from 17 to 20 years in girls and 18 to 22 years in boys. There is a deceleration of growth, closure of growth plates, and attainment of final adult height. So this is how an ovum transforms into a mature adult. Now back to our question about the observations of a growing child. Have you observed a newborn? What do they do most of the time? They either cry or they sleep, right? But have you seen any tears in a newborn? Yes. So it is kind of paradoxical that they spend so much time crying but produce no tears until 3 to 4 weeks of age because of the immature lacrimal glands. It's only after that that they start producing tears. And for premature babies that are babies born before 37 weeks of gestation, they produce tears a little bit longer than normal um, the 37-week delivered babies. Now, the premature babies can as such be classified into extremely preterm, very preterm, late preterm, moderately preterm, and then late preterm. That is, extremely preterm is before 28 weeks of gestation. Between 28 to 32 weeks is the very preterm. Moderate preterm is 32 to 34 weeks of gestation, and late preterm are the babies born between 34 to 36 weeks of gestation. Um, so, depending on the height, weight, and head circumference at the time of birth, these premature babies can be classified into three further categories, that is AGA, SGA, and LGA. AGA means appropriate for gestational age. SGA is small for gestational age, and LGA is large for gestation age. For this, we use the Spenton charts for preterm. So in this Venn chart, we can start plotting the height, weight, and head circumference at the time of birth. In this, if we find that this is less than 10 centile, we classify them as small for gestational age or SGA. Between the 10th and 9th centile, they are termed as AGA, that is appropriate for gestational age, and more than 90th centile is LGA. This is an important tool used in NICU setups to identify a child's growth characteristics. Apart from this, there is another classification based on weight, that is low birth weight, low birth weight, very low birth weight, and extremely low birth weight. So low birth weight infants are the ones that are weighing less than 2.5 kgs. Very low birth weight are those infants weighing less than 1.5 kgs, and if the weight is less than 1 kg, they are termed as extremely low birth weight. Similar to the Fenton charts, we have weight charts for each age, which is different for boys and girls. In this, we can find out the percentiles for height, weight, and head circumference. All these three together are called anthropometry. And because of this, we can find out whether the age is appropriate for age or weight is appropriate for age or not. And because of the advancement in technology, now we have apps for finding out centiles, and so that we don't need to physically plot them in these charts. And in India, we have this Indian Academy of Pediatrics app to calculate the centiles. Okay, now that we know the basics, let's move on to the diagnosis of growth disorders. How do we diagnose? First of all, we need to keep in mind that early diagnosis is very important for better outcomes, but at the same time, early diagnosis is challenging as many growth disorders are not noticeable till around mid childhood. So for this, there are key very important evaluation parameters, that is the birth history, which includes gestational age, birth weight and length, head circumference, delivery type, birth trauma, hypoglycemia, prolonged jaundice or NICU stay, then past medical and surgical history like head trauma, surgery, cranial radiation, or CNS infection, which can all affect growth adversely. Then, review of systems is very important. The eating habits, appetite, bowel movement, headache, or vision change should all be taken into consideration. Chronic illnesses such as anemia, inflammatory bowel disease, cardiovascular disease, and renal insufficiency, etc., may also affect growth. Then, family history is also very important because consanguinity may lead to genetic variation. Consanguinity is if the parents are related by blood, it will lead to a lot of genetic conditions, which we have seen in uh, a lot of um disorders. Then parents and siblings height also affects the. It is also related to the child's height. Family history of short stature, delayed puberty should also be confirmed. Then physical examination like body proportions, upper lower segment ratios, arm span, head circumference, microphallus, dysmorphism, and midline craniofacial abnormalities. Then growth patterns again should be checked, crossing of percentiles and failure to catch up. Then there are screening tests, which includes a normal blood test and bone age measurement. That is just we can take an X-ray, and then um, depending upon the growth plates and the bone maturation, we can calculate the bone age. Now, moving on to the disorders of growth. Short stature is the falling of height below the third percentile. That is, if the child's height is below the third percentile for that age, this child would be particularly lower in height than their peers. Then, failure to thrive is inadequate weight gain or growth below the expected norms. Here, the weight also falls below third or fifth percentile. Then we have disorders of head size and shape. Macrocephaly refers to a higher head circumference than the expected, and microcephaly is just the opposite. There is a small head or lower head circumference. Then craniosynostosis is the premature fusion of one or more cranial sutures causing abnormal skull shape. Then there is growth hormone deficiency and insensitivity. Endocrine causes leading to impaired somatic and skeletal growth, and this is characterized by low growth velocity and delayed bone age. Then there are nutritional disorders affecting growth, that is protein energy malnutrition, micronutrient deficiencies like calcium, iron, zinc, iodine, and vitamins A and D, leading to stunting, wasting, and poor growth. Then there is infectious causes, as mentioned earlier, that is recurrent infections will impair growth velocity and nutritional status. Then there are skeletal dysplasia. That is the congenital disorders of bone and cartilage formation causing disproportionate short stature and skeletal abnormalities. Then we have genetic syndromes that includes Turner syndromes, Down syndromes associated with short stature, and Sotos and Klinefelter associated with tall stature. So this is an interesting photo in which we have the tallest human living and the shortest human. The tallest person, he measures a astonishing 8 feet 2.8 inches, while the shortest living human right now, she is also Indian. She is just 2 feet and 0.7 inches in height. So the contrast is very visible, right? Both of these are affected by growth hormone, growth disorders, but there is such a big contrast. Then the treatment. There is nutritional support that should be given, that is very important. But if the cause is genetic, nutritional support may not be very effective. Then psychosocial support in conditions such as FSS, parents needs to understand and emphasize other achievements of the child instead of focusing on stages so that their self-esteem does not suffer. All forms of vigorous exercise should be encouraged and they are beneficial for a variety of reasons, but none of them are specifically meant to improve height. The pharmacological treatment is with the recombinant growth factor. So, the recombinant growth factor treatment has been found to be effective and safe. It helps in improving linear growth, achieving adult heights in the normal range, improving body composition, bone mineral density, cardiovascular outcomes, and quality of life. So, the indication for recombinant growth factors is proven growth hormone deficiency and in some girls with Turner syndrome. And there is one RHIGF1, which is the growth factor used for primary severe IGF1 deficiency. And in this, the timing of treatment initiation and dosage is very, very important. There are approved weekly growth hormone preparations now that reduce treatment burden, increase compliance, and improve clinical outcomes. Um, because earlier it was daily growth hormone administration, but since there is a weekly approved growth hormone preparation now, it has improved compliance and it is better tolerated. Okay. Okay. So the growth hormone dose for different conditions um, is mentioned here. It is given in mg per kg per week. As I mentioned earlier, it is a weekly formulation. So for growth hormone deficiency, it's 0.16 to 0.35 mg per kg per week. So if the child's weight is 10 kgs, we can give 16 to 35 mg per week. Then for children of prepubertal prepubertal growth hormone deficiency, it is 0.16 to zero point 0.7. Then for adults, it's 0.04 to 0.175. And then there are same thing is given for different conditions. And this brings us to the end of the presentation. I hope you have learned something new here. And so the key takeaways from this presentation are normal growth versus disorders of growth, factors influencing growth, what happens in deficiency versus abundance. Then there are appropriate terms for each child in each growth phase. Um, Identification of key growth disorders through growth charts, clinical manifestations, and genetic causes. So, thank you.
Okay, so thank you, Priyanka. I think that was very informative, and you have actually created a base for us regarding growth. So, just one question, like, have you come across any real life examples or any case scenarios where you had children with issues of growth or any other treatment options? Have you come across any such cases?
Yes, I've come across cases, but since I'm involved in neurology, the treatment part, I'm not, I was not very involved in that. But recently we had a child with eosinophilic meningitis, in which actually, she's just 11 months old, and they came primarily for the treatment of eosinophilic meningitis. But incidentally, we discovered that she had failure to thrive. Her all her centiles were below third centile, but the parents had not noticed it before. But because of this acute, this condition for which they came for treatment, this could be identified, and now they're undergoing treatment for that also.
So, is the growth hormone regarding the treatment of growth hormone also, is it like readily available in India? Or like, do you know like what is the cost and all? Just any other knowledge about the drug?
Um,
How are we
I think
giving it? Is it IM, IV, anything related to the drug?
uh, yeah, so I think it is very available in India. Um, uh, I think endocrine departments do have growth hormone injections that are given here. Um, I'm not really aware of the cost as such, but I don't think it is very costly because there are a lot of families that undergoing treatment. Um, and yeah,
I think because it's a weekly dose administration, it will be better for the children too, right? Like daily, before it was daily dosing and all,
yes,
it would be very difficult, especially when in the children age, taking medication, the adherence and all will be very difficult, be very difficult for the parents too. But I think when it became a weekly dosing, definitely it became better, right? The
yes,
adherence
yes.
rate would have definitely gone up. So thank you so much for giving us the base. So definitely we're looking forward to the next part, that is development. So in development, I think we'll be learning about the milestones and all that will be more interesting, right? A very interesting topic too. So thank you so much, Priyanka, for taking this class for us.
Thank you so much.
Looking forward to more sessions from you. Thank you.
Pleasure having you.